Hello, good afternoon. Okay, thank you. Thank you, Dr. Wexner. So Dr. Wexner asked me here today to talk to you about basically the preoperative imaging of rectal cancer. The idea for my talk basically wanted to present a practical, evidence-based approach to imaging the patient and improving outcomes. I'm going to go through all the imaging modalities we have, including those that evaluate local regional disease and those to evaluate distant metastases, and go through these in a systematic fashion, and hopefully it'll be practical and concise. The goal with local regional imaging is there's multiple goals. First, we want to look at the primary tumor, look at the depth of invasion. Second, we want to see its distance from the sphincter complex. Third, you want to see what the potential is for achieving negative circumferential margins. And fourth, you want to look for involvement of local regional lymph nodes or adjacent organs. There have been many studies. Most of these were done in the late 90s, looking at and comparing endorectal ultrasound, MRI, and CT. And there's a lot of there are a lot of studies showing, basically evaluating the T and N staging of the ability of these modalities for T and N staging. When you look at the results from these studies, they're kind of all over the place. There's a wide range of accuracies, a wide range of sensitivities and specificities, and there's a lot of overlap. So when you look at all these older studies, it's hard to know what is the best imaging modality for T and N staging. But given that, most people agree that endorectal ultrasound is probably the best modality for T staging. It gives us the most accurate T staging. But as you can see, there is a wide range of accuracies when you look at all these, all the references, and the reasons being probably because of its limitation. Number one, the operator dependency. And that's probably what gives a wide range of results. There are other limitations to endorectal ultrasound. The fact that stenotic tumors and upper rectal tumors may be difficult or impossible to evaluate, and the limitation of the depth of acoustic penetration, meaning you're limited to the bowel wall and just beyond the bowel wall, but evaluation of the mesorectal fascia and pelvic organs is limited. Endorectal MRI is a good idea. When you look at the comparison studies, it's actually pretty similar to endorectal ultrasound for T staging. And it also suffers from the same limitations, those based on the fact that it uses an endoluminal detector, basically. So you're going to have the same field of view imaging, field of view limitations. You're not going to be able to see the mesorectal fascia or the adjacent pelvic organs. And you're going to have the same problem with stenotic tumors or high tumors. Additionally, it's very expensive. Those endorectal coils are disposable. They're used once and discarded, and they're expensive. And it's uncomfortable. A patient has an endorectal coil for 30 minutes. MRI with phased array coil, what that means is what you see in the picture. The detector is laid on the patient's pelvis. It's not inside the patient. It's much more comfortable. It's really something that has a lot of promise, or has had promise, and is where we're looking in the future. When you look at the results, again, it's a wide range of accuracies when you look at all the different studies. More recent studies are in the higher end, which show that this pelvic MRI is very comparable to endorectal ultrasound for T staging. The greatest limitation we have with MRI, though, with regards to T staging, is the distinction between T tumors and T2 tumors and subtle T3 tumors. What happens is the T2 tumors have associated inflammatory and fibrotic changes that can lead to overstaging. Here's an example from the literature. And what you see here is a pathologically proven T2 tumor. It's confined to the bowel wall. And on this MRI, you can see this peritumoral desmoplastic reaction, which mimics a T3 tumor. The one thing, even though MRI may have its limitations with T staging, the one thing that sets it apart is the excellent depiction of the mesorectal fascia. As you can see, these red arrows point to the mesorectal fascia, this thin black line on these T2 weighted images. And this is very clearly seen on these MRIs. And what that means is we can predict the circumferential resection margin. In other words, you all know that a positive or negative CRM is going to be a better predictor of outcome than just the T stage alone. And it's been shown that MRI very accurately predicts whether or not you're going to have a positive CRM with up to 95% certainty. By measuring this distance, you can see with the green arrow between the tumor and the mesorectal fascia, a distance of greater than 5 millimeters is very predictive of a negative margin. Additionally, because of the good field of view you get with MRI, you can evaluate another prognostic indicator. In surgical series, tumors that extend more than 5 millimeters beyond the muscularis propria have a much worse outcome than tumors that extend less than 5 millimeters beyond the wall. And MRI was equivalent to histopathology for predicting this. So in summary, MRI with the phased array coil, a comfortable exam, not an endorectal exam, allows excellent visualization of the mesorectal fascia, and greater field of view, which allows us to more precisely prognosticate. In other words, we can look at this extramural depth of tumor invasion, and we can predict negative CRMs, and therefore we can have some prediction as to what the outcome is going to be. And treatment can be adjusted appropriately and individualized to the patient. MRI is also used for locally advanced cancers. It's the best modality to show pelvic organ invasion, pelvic wall invasion, and subtle bone marrow invasion. I'm not going to talk a lot about nodal staging, except to say that as with all other tumors, imaging is limited for nodal staging. The best we can do is we're still missing about 20% of malignant lymph nodes. So nodal staging, we still have work to do in that regard. And there is some work with MRI trying to improve that. The metastatic evaluation, as you can see, there are many tools you can use to evaluate for metastases. CT is really the mainstay and has always been. A CT scan of the abdomen and pelvis using IV and oral contrast is very useful for showing complications from tumor. So it shows us perforation and obstruction. And it's very good for liver metastases. It's the most frequently used tool for that. MRI in older studies, which compared them head-to-head, had similar performance to CT for detection of hepatic mets. Although if that same study were carried out today with today's technology, it might be a little bit better. And MRI is also better for small peritoneal and bowel mets. So there is an argument to be made that MRI may be better than CT for looking for metastases. However, it is expensive and it is patient dependent. For every good MRI scan, you're going to have a bad one. Patient with ascites, patient can't hold their breath, patient that moves. So it is very patient dependent and not always reproducible. However, it is a good alternative and a very good alternative whenever CT contrast is contraindicated. Another question that's discussed in literature is whether or not we should use chest CT to evaluate these patients. On the one hand, pulmonary mets are rare. One study showed less than 5% yield for chest CT compared to chest X-ray. And another study showed no treatment change when chest CT was added to the imaging protocol. However, a more recent study showed that it did improve the overall staging, and it also identified nodules and provided a baseline for these nodules so that on follow-up imaging, you knew whether or not there were new mets or change. So if anything, a chest CT adds value in that it adds a baseline for future comparison. PET CT studies have also been mixed. And one study showed pretty dramatic findings. Patients with rectal cancer imaged with PET-CT, there was a change in management in 27% of patients. Almost all of these were low rectal cancers. Another study that looked at colorectal cancers in general showed only a small percentage of patients had a change in management. However, if the truth lies somewhere in between, you can see that using PET-CT on all rectal cancer patients is not something that could be useful. It can be argued for. This is an example from that second study I mentioned. You can see in these PET-CT images. On this patient had no metastases on conventional imaging, meaning CT scan, and had a follow-up PET-CT scan which showed this FDG avid nodule in the rectum, and then a solitary metastasis in the liver, which was not detected on imaging earlier, and probably because it lies right on the hepatic vein. But patient management changed based on this finding. So in summary, endorectal ultrasound and MRI with phased array coil are complementary tests. Endorectal ultrasound is the best for T staging, particularly small tumors, meaning T1, T2, and small T3 tumors. But MRI adds value for more precise prognosis based on its greater field of view, ability to visualize the mesorectal fascia and other pelvic organs. For metastatic disease, PET-CT is going to maximize disease detection and possibly change management, and should probably be used, especially in patients with low rectal cancer. CT scan of the chest, abdomen, and pelvis with IV and oral contrast is probably more commonly used than PET-CT, so it's definitely an acceptable alternative to PET-CT if PET's not available. Either way, PET-CT and MRI are excellent alternatives. They're useful for problem solving. They're useful whenever you have an equivocal CT scan, and they're useful whenever a CT scan is contraindicated because of IV contrast allergy or borderline renal function. Thank you.